Um, just to echo Eamon's comments, hugely appreciate the invitation. I think it came as a bit of a shock to some people yesterday that Eamon and I knew each other. We have been partners in crime for many years, and he is a force of nature. I'm going to take a slightly different tack to, I think, what the current flavour of the conversation is, and I like to be quite contentious and offend people. So I'm actually going to approach this as a conversation, but really through the lens of asymmetries of power, i.e. we have all the power, and it very clearly affects not only how we deliver our services by extending that power, but it seriously affects the outcomes for the people who are the most vulnerable in our society. This is us. We are an outreach service. We were established following a pilot in 2002, which is quite a long time ago now. And I'll take you on a relatively short journey over a couple of decades, where we've really evolved from being a service that we set up under the auspices of tuberculosis prevention and control. I do like a bit of TB. And that service has really evolved into a service that's now still quite infection focused, but nevertheless far broader in terms of its aims, its aspiration, etc., and certainly its workforce, as you'll learn soon. I was quite surprised so far not to have heard the word syndemic. Has everyone heard of syndemic? It's a great concept, comes from anthropology, like a lot of the really sensible stuff does, way outside of the purview of biomedicine. But syndemic is a really interesting lens to view and understand what inclusion health actually is. So I'm gonna kick off with that, and then I'm going to talk about the service, but in terms of the principles applied in terms of those inclusion health principles and how we have tried to model a response based on sound evidence, but nevertheless doing the right thing. And finally, my latest buzz is the concept of equity in everything, but certainly equity in elimination. We've all signed up to eliminate, it's a good word, isn't it, these nasty bugs, viral hepatitis, HIV and TB. We've all signed up to eliminate them, but I hope to throw a bit of a challenge to you as highly intelligent thinkers to join what I think is a growing mission, a growing realization that we cannot work alone in this agenda, and we need to get out of our pathogen specific silos and move into a far more united and people-centered focus. So let's kick off with some measurement. I've made quite a lot of progress through measurement, I think, and perhaps coined the term making the invisible visible, which is really one of the essences in terms of good epidemiology. You know, they say epidemiology is making a perfect statement from imperfect data, and ultimately that's what I think was missing in terms of a lot of the thinking internationally, was some genuinely robust insight into what was a very opaque and murky water. I don't like doing systematic reviews. I think it can drive anybody mad, but this was a big one. And we, for the first time, tried to do a proper evidence synthesis and meta-analysis on every single data point we could find in terms of high-income countries, papers reporting differential morbidity or mortality across the ICD-10 dictionary. And we spent a long time to actually produce this paper as part of a Lancet series that we got on inclusion health. And it really did open my eyes to something, just in terms of the sheer magnitude that I think we'd missed. We all understand standardized mortality ratios, and we all understand this very, very clear relationship between your wealth and your health. And we commonly in the UK stratify our population by indices of deprivation. This is indices of deprivation representing the poorest on this side, the richest on this side. And men, being the weaker sex, usually fare worse across this spectrum. When we were able to transpose the SMRs for the inclusion health populations from these data, it blew my mind, because the SMRs were literally off the scale. If you're thinking about people in the most extreme concept of hardship as measurable within data, experiencing what is almost an unseeable. Sorry, it's advancing automatically. Is it possible to stop it? There seems to be no difference, between here and here. We're pretty much level on the mid-ground here. But when we introduce homelessness, imprisonment, the hard end of the stick, we start to see a complete inversion in what was usually accepted wisdom as men being more susceptible to premature mortality. And an SMR of 12 in women is just mind-blowing. We really truly don't understand that yet, but there needs to be some proper inquiry into this. So, bit depressing, but this pretty much sets the scene, and we're actually talking about early preventable death for a range of conditions. But again, I'm not going to bore you with the data because there's too much to cover in this talk, but exactly to resonate what Eamon was saying, we're not talking about, we're talking about comparative SMRs that are eye-watering in terms of suicide, overdose, etc., but the big killer ticket items are exactly as for you and I: cardiovascular disease, cancer, respiratory, etc. And so it's a failure of early intervention, and it's a really clear early onset of complex interplaying multiple morbidity. And therein lies the beauty of syndemic as a concept. Syndemic is literally a biosocial concept of health. It walks us away from the idea of, pardon Robert, the pathogen being entirely responsible for the patterns of disease that we see, and starts to open the door for us to understand how social forces are driving the constellation of disease in different population groups. And perhaps more importantly, how this structural social violence around us that's perpetrated very differentially on different groups within our population starts to manifest in terms of clusters of disease that have a very adverse interaction upon one another to compound the situation and make things worse. And fundamentally, syndemic takes us into the realms of understanding not only in the intersectorality between our biology and our social environment, but also the intersectorality between the labels that we apply to people in that environment. And, again, we've moved away from the idea of a service for people experiencing homelessness. We've moved away from the concept of just compartmentalizing and labeling people as you're homeless, you're a sex worker, you're a prisoner, you're a migrant, you're a drug injector, etc., etc. If you enter any one of these domains, the risk of entering all just increases exponentially. And understanding that intersectorality, I think, is really important, from not only from the point of view of being able to communicate to people, but perhaps most importantly from the perspective of being able to design more effective services to meet their needs. And syndemic is writ large in terms of not only the overlapping populations, but the overlapping risk factors, modes of transmission, etc. The more we understand about this complex interplay, this early onset comorbidity, and in terms of infection, co-infection is extremely common, the more we realise how hard it must be to try and use the services. You could very easily become a full-time patient. You could have TB Monday, hepatology Tuesday, HIV Wednesday, psychiatry Thursday, might give you a day off on Friday, I mean, you would be a full-time patient. And I don't use the word lightly, but I think failed by care should be a word that enters our language. This is too dense a slide, but it just clearly illustrates the overlapping common themes in terms of, as we understand risk, in terms of STIs, viral hepatitis and HIV. And I think this really starts to drive home the idea that, you know, siloed services are missing a trick in not only understanding what they can learn from one another. I've learnt an enormous amount from HIV. You know, just a nothing about us without us concept, to apply that across the board in terms of other services would be a monumental step forward. And so what we're sort of moving to in terms of, I hope, the conversation in this room is this idea of the intersection, and this idea of amplification within the intersection, and this idea of R naught, which we can now use as a concept in the pub following the pandemic, which was probably the only good thing that came out of the pandemic, is everybody got a crash course in epidemiology, and everybody now understands the reproductive force of infection of any single pathogen. They don't, but nevertheless, it's quite crucial to this as a concept. And so here is a slide that explains inclusion health. This is inclusion health. Now, we like to live in the safe zone, which is the green area around, and consequently, because we like to live there, we also like to work there. And we've put all our services in the nice, safe green area on the periphery to this rather dangerous, unknown area in the middle. And consequently, we've kind of developed this idea of, you know, we work from the outside in. You know, any health intervention is all about the low fruit, isn't it? Everybody likes to pick the low fruit. And, you know, doing the easy work is great. And we've actually designed a service that triages all the complexity out of the system before it even gets in front of our face. Because we sit in our nice buildings and we wait for people to come to us, and we establish the power dynamic. They sit on that side. I'm on the podium, clearly, and looking down on people. An incredible asymmetry of power. And when we start to apply this to infection, a real risk, a real failure, because, you know, here is the engine house of transmission. This is where the action is, and we're all sitting on the outside looking in, calling them hard to reach. It's the services that are hard to reach, isn't it? I mean, the patients are not hard to reach. You walk into any hostel in Birmingham or Berlin or Manchester or London, and you say to the manager of that hostel, I'm here to see your hard to reach patients, you know, and he'll look around and say, well, you know, I can't get rid of them, you know, I mean, like, so language is important. So from the perspective of this as a conversation, this is what inclusion health looks like. And it's fundamentally getting to the middle and working out. And this is how I think you do it. You do need to reach. You do need to reach. And in the concept of infection, you need to reach early. And outreach is one of my favorite words. It's really easy to type as well. It's all on the top of the keyboard, a little bit on the middle. But outreach, I like to think in terms of go-to, and outreach is a nice concept in terms of just taking services to people, absolutely inverting that logic. But I've kind of grown more into outreach as the initiation of what is a continuum of care, which is really into the mobile health domain. And that to me is all about going with. So we have going to people and going with people. And there are a myriad of opportunities in terms of modern technologies to go with people. Second is to engage. You know, people ask, what do I do? And it's a difficult one to answer, but in the simplest answer is that, you know, what our team does is we build relationships. We fundamentally build relationships. First and foremost, we're building relationships with people who have been failed by care, by the system. And that's our first job. And in order to achieve that, we need that magical ingredient of trust. And trust comes through the abandonment of power, I think, in many ways. And in order to achieve what we have achieved, we've had to absolutely recognise that we can't do it without people with lived experience. The entire service, the fuel of the service, is driven by people with lived experience who've been there and seen it and done it. And they understand people's situation. They understand people's priorities. They're not my priorities. I would say your arm is falling off. That might not be that person's priority. They would say, I'm absolutely clocking and having a complete mental health crisis. I don't care about my arm. And the reality is, to engage with people meaningfully is so important because it sets the tone for a journey. And I like to talk about TB treatment and Hep C treatment and getting on your ART as a journey. And we have milestones on the journey, and we go with you on this journey. And that care is organised in a way to be sticky. I like the word sticky because we stick with people. We keep going. We will follow you and stay with you and advocate for you as long as you need us. From a tech perspective, I've ditched the term point of care. I don't like point of care. I like point of decision. I want a tool that will tell me what to do next, so I can instantly do something else and then do something else and then do something else, and get all these care cascades squeezed like an accordion into a very, very, very tight one-stop shop opportunity. And then last on this list in terms of the principles is cure, which is a word that unfortunately remains almost wholly owned by biomedicine, and through the lens of infection is really abused in the concept of, you know, if I pick you out of the gutter and hold you in front of my x-ray plate, see you've got a nice big cavity, throw some of your sputum in my expert machine, give you the right regimen, carefully pop every pill inside you, and then gently put you back in the gutter. You know, are you cured? No. We need to, we're desperate globally for an intelligent biosocial concept of cure that ultimately encapsulates the determinants. We're making progress in terms of getting people to think along those lines through viral hepatitis, where people are genuinely worried about risk of reinfection. There's no point in taking a course of very effective direct-acting antivirals if you've got no access to clean needles and safe injecting equipment. But fundamentally, the best outcome for us in terms of cure is a job. And quite a lot of the people who work for us actually started their journey by us going to them. In terms of people on the move, London's an interesting lens, isn't it? I'll throw this up. I pulled this off our system a couple of days ago. In the last 24 months, we have seen people from 175 different countries on this planet in London. A lens onto the world. There's only 195 countries on the planet. I'm really keen to meet someone from the Vatican or Vanuatu, but I haven't found them yet. In terms of going to people, we started with a big old van, a big old truck. This is the second, well, in terms of complete rebuild, third iteration of mobile digital radiology up here. And that's been an interesting journey. Our record is 599 people imaged in one day. You know, you can seriously chew through radiology, and I'll talk to you a little bit about how this has evolved. But increasingly, we've been getting smaller and smaller and smaller. And was in Berlin last year to collect this, which was built here because post-Brexit, you know, we've gone back to basically sharpening stones. So we had to come to Germany to get this built, and this is a concept in its infancy. It works. There's more tech on that bike than there was on the original van that we put together, which is amazing. It's got expert. It will soon have radiology. It's cloud connected, etc., etc. But we also do an enormous amount out of bags. You can do an incredible amount of healthcare from a well-packed bag. But the whole aim is to basically ensure that there's something for everybody. This idea of integration is not only important from the perspective of ensuring that people's needs are met, etc. It's also incredibly important from the perspective of value, opportunity. We call it making every contact count. And, in terms of we've been evaluated to death. As soon as you stick your head above the parapet and do something different in the health system, people will try and shoot you. And we've survived by basically meticulous evidence and demonstrating our worth. But we've never been evaluated as an integrated service, because even the best health economists don't seem to be able to get their head around the idea that doing more than one thing with the same team on the same unit out of the same bag, etc., is just adding value. Nothing is undermining our cost effectiveness. It's pushing us in the right direction. Having said that, we're highly cost effective, potentially cost saving for TB alone, highly cost effective, potentially cost saving for Hep C alone, etc. And that doesn't take into consideration any of the other value that we add. TB, I was trying not to bore you with lots of numbers, but I will throw a little number at you in terms of TB, because we're going up for the first time in quite a few years. That's common across Europe, and I think will remain common across the world. But what's hidden under the curve is a radical change in terms of the concentration of disease into inclusion health populations. TB is a bug that finds its niche in human suffering. It is a barometer of social justice internationally, and the proportion of cases with a history of street homelessness, injected drug use, imprisonment, etc., in the UK has doubled. They've gone up from 8% about 10 years ago to overall 17% now, and in many services, many inner city services, it's 1 in 3 of the TB cases have now got extremely complex social risk factors. In terms of point of care diagnostics, we're very fortunate to be able to work in a negative pressure environment. It's called the pavement, so I can safely harvest as much sputa as I like. This trick, which we published, a pot with a septum on it, enabled us to take expert out of the laboratory into the community, and now into prison, many other places, for a on-the-spot diagnostic. But in terms of technology and time moving on through this 20-year journey, my radiology has gone from 11 tons to 3.5 kilos. That's quite a journey. My highly unionized but wonderful radiographers soon to be replaced by an AI engine on the cloud, and the AI engine is performing better than some of the best human eyes on this planet. And the opportunities to take diagnostics to people this is the 21st century for healthcare. And again, as Eamon was saying, this idea of community dividend, inclusion health provides an opportunity to test these concepts to destruction, but in such a way as if it works effectively there, it's going to be an enormous step forward for everybody. Nobody really wants to go to hospital. People like the idea of owning their own healthcare, etc. People like digital. But back to building relationships, back to being sticky, back to being trusted. I like the concept of lived and learned, in a way of trying to explain what it means to actually try and design a service that's in partnership with people who have lived experience. We all have a bit of lived experience. We all have a bit of learned experience. Some of us have got a bit more of one than the other. But the magic happens in the centre. The magic happens when we get that perfect balance between lived and learned experience. We get that shared unity of purpose, as it were. And that's a magic not only in terms of how people perceive us, but it's also magic in terms of what we perceive to be the art of the possible, and it really drives innovation. It's really an engine house for research. There's nobody in our team who isn't research active, and the ideas that come out are quite mind-blowing. And we work in a reasonably rigid, but nevertheless, rules are there to bend system, and we've been able to radically extend the role of people with lived experience within the service to take them away from the usual concept of, yes, we work with peers. Yeah, we put them on our website, we roll them out at meetings, and they talk about how great we are. No, the idea for us is this is a value, an essential member of the team. The evidence says we can't deliver our service without this model. The evidence is becoming increasingly clear that we cannot deliver high quality services for people in the engine house of transmission unless we deliver them in partnership alongside through people with lived experience. And we've extended their role way away from just talking to being actually teachers. They operate all the kit. They dispense the treatment. They stick with people throughout the journey, and they train health professionals now. And this idea, Hep C was a wonderful example. I mean, TB, I like TB, but let's face it, the diagnostics are rubbish, the treatment's rubbish. I mean, Hep C is a real bug you could eliminate. If you want to talk about elimination, talk about Hep C. Hep C, we've gone from, nasty pegylated interferon with, awful side effects and a 60% chance of SVR to 8 weeks of mother's milk and a guaranteed cure. And so we've really had to rethink how we do it. And everybody's familiar with these cascades, and I just made this one up, but it's still a reality all over the world. We're just giving people multiple fragmented appointments to get to the end of their journey. And it's again a really interesting and measurable epidemiological fact that we as health providers, we actually give the most appointments to the same people who are least likely to attend any. We genuinely undermine their healthcare by making it complicated. So, we did this pre-pandemic. We squeezed the entire Hep C cascade into an entirely peer-led engagement antibody test straight into an expert, an Omni on the street, FibroScan, pangenotypic regimen, go. And so we could take a care cascade that was taking weeks and squeeze it into a health event that took about 90 minutes, 2 hours. That's progress. Peer linkage to care is where it's at. I'll accelerate. Highly cost effective, can't argue with it. The idea of adding effectiveness through integration is gaining ground. Don't let anyone tell you it doesn't work. Adherence or compliance or concordance. We've got some strange language, haven't we, about taking pills. Compliance, well, that's a bad word. Adherence sounds like glue. Concordance is an aircraft. I like take. We got to get people to take some pills. And fundamentally, it's not that complex. It fundamentally boils down to can't do it or won't do it. Won't do it is a very interesting conversation, particularly around airborne diseases. No time for that today. But can't do it is something that should be a thing of the past. We're sticky, and we're sticky throughout, and we achieve the same, if not better, treatment outcomes in the population, the people that we serve, than is achieved in the general population. We've done it by playing a few tricks. One of the first things we do is we talk well, and I try and frame this around the idea of aim. There's so much value in actually ensuring that somebody actually understands what the hell you're talking about. When you look at the adherence literature and you start to unpack it, it's really interesting because quite a high proportion of what we call non-adherence is actually unintentional, and it's associated with poor communication between providers and patients. Getting people aware, getting people to accept the diagnosis to believe. It's all a faith-based exercise. I can write the world's perfect RCT and publish it, but fundamentally you have to believe it. Yeah? Everything's fundamentally subjective. We have to make sure that we've covered the basics, and we start with aware, informed, and motivated, and able to act in your best interest, to have agency is where it's at. Taking pills shouldn't be a punitive thing. Taking pills should be something that you make a conscious choice to do in your best interest. And we do get, pretty good treatment outcomes. For some, the treatment model is somewhere to live, and it has to be. For TB in particular, when we first started, hospitals were very comfortable with the idea of giving someone 20,000 euros worth of pills in a carrier bag and sending them to their park bench, but they didn't feel it was really appropriate to offer them anywhere to live. We opened a TB respite centre. We've recently published this, and we won't bore you with the methodology. It's pretty robust, but if you go in to that centre, you're 3 times more likely to complete your treatment. We didn't have enough power for death, but we certainly had a strong direction of effect there. So that's the extreme end of the wedge in terms of a model. That's highly cost effective. The majority of the people who went into this project were XDR or MDR. The treatment outcomes are 90% plus. We need to prevent 1 or 2 transmission events a year to pay for this project 2 times over. It works. This was a bit of a breakthrough. First RCT globally on active TB, giving people a smartphone. And when I say giving people a smartphone, our population are the only candidates for DOT, don't like the word directly observed treatment in the UK. We don't have a universal program like the Americans. We targeted at people who we assume through our crystal ball gazing skills are not going to take our pills. We had to stop this trial early because a pre-planned midpoint analysis demonstrated that it was unethical to continue. This is now into WHO guidance and I think is in its infancy. And we use increasingly smartphones. We give people smartphones. Access to the internet is a human right. We give people smartphones at the start of pretty much all our treatment journeys, and we use it not only to remain engaged with them, as a lot of them call it, to be the nurse in their pocket, but it also opens the door for 1,000,001 other opportunities. You can't even make an appointment to see a GP without a smartphone these days. That works. But it's all a Trojan horse. I'm just using this all as a flimsy excuse to get paid to get out there and meet people and do more interesting things. Reality is infection is an interesting area to work in. It certainly isn't the #1 priority for the population that we're serving, and their needs are vast and diverse. We started to do a lot more work in terms of the art of the possible as far as getting people diagnosed and plugged in for a smorgasbord of non-communicable diseases. Back to the real big ticket items in terms of early preventable mortality. The reason why people disappear off my radar, the main reason why, is because they've had a stroke in their late 30s or 40s. And when we talk about frailty and we apply measures of frailty, validated instruments of frailty, one of the big successes of the recent NICE guideline that we wrote for improving health and social care for people experiencing homelessness was to get frailty on the map and to actually say that your access to a package of care should relate to your health need, not your biological age. That was a good step forward. And so most of this is unmeasured in terms of what we as a team do, but nevertheless, it's an enormous amount of our work. Getting people plugged in, getting people access to the care that they need. Huge amount of undiagnosed and unmanaged mental illness in the population, and an enormous confusion between overdose and suicide. Increasingly, I'm moving into a colleague we both know in Dublin called Austin O'Carroll. He's written some really insightful stuff on this, and the number of deaths of despair, in inverted commas, that are occurring on the periphery, unknown, unmeasured. But one of the things that really blew my mind from some of the frailty work was the sheer level of brain injury in the population that we serve. And the amount of cognitive impairment that was there, and a huge number of people who, if they were born into the world today, would have been clearly identified as having learning difficulties as a child, and their opportunities, their life chances would have been vastly different. They wouldn't have ended up using our service. And an enormous amount of safeguarding. We think being a rough sleeper is unsafe. We think being a lone vulnerable female on the street being pimped is unsafe. We push this legal framework around us as hard as we can. We've trained a lot of people to be more legally literate. I think getting legal literacy on the agenda for the entire health and social care agenda is a way forward. This has been mentioned. We're doing a lot more of this. These are this week's. We're not that sure about the legalities of it, but as we've discussed earlier, we do prefer to ask for forgiveness rather than ask for permission. But we are testing. We're the only people doing this in London, as far as I'm aware. We're basically supporting people to test their own gear, and everything is contaminated with nitazenes. We're not seeing fentanyl, we're not seeing xylazine, but everything is increasingly contaminated. And the harm reduction agenda in the UK is a very, very sorry story over the last few years. In fact, it's a madness. We've invested an enormous amount of money into eliminating hepatitis C, whilst completely disinvesting in harm reduction services. So again, this is an agenda that we need to understand how to take to the street. The drugs market is the world's perfect free market. If we can empower the customer to know what they're buying, surely that's going to have a positive effect. Any capitalist would agree with this. And we are trauma informed. Fundamentally, again, back to the importance of having a peer-led model. We need to understand the context in which people use our service and the context in which they have to try and live with stigma, prejudice, racism, etc. And Eamon touched on this thing called ACE, Adverse Childhood Experiences, which is absolutely writ large across our service. People aren't homeless because they've lost their key, people aren't taking enormous, dangerous quantities of crack cocaine and heroin because they're having a great time. When we start to drill into the UK-born people that we serve, 45% of them were abused as children. 1 in 5 were taken into care. 53% have been to prison, and 55% left school with absolutely no qualifications whatsoever. They were failed very early on in life. This journey started very, very early on through the accident of birth. They made very poor decisions in terms of their parents, and they've been punished for it throughout their lives. And the reality is, I can spend my life standing on the bridge trying to fish bodies out of the river. That's an interesting thing to do. Some of them are even alive. But the hard work starts upstream, and we've got to invert this entire agenda into an evidence base of prevention rather than cure. So we do a lot of stuff. This is pretty much the core services that we provide. We're outreach testing, active case finding, we immunise a lot of people. We support people through 1,000,001 different treatment journeys. We use a lot of technology. We try enormous amount of residential respite care for people. New kid on the block is R2C, return to care. We get referred hundreds, if now not thousands, of people who have engaged with the system to the point of diagnosis, but then become hard to reach. They've failed to respond to a couple of stern letters that have been written to their park bench, and they've been written off, or increasingly they've rocked into an emergency department, had an opt-out test. They weren't even asked. The posters on the wall, you will be tested for HIV, Hep C and Hep B unless you run screaming from the building immediately. The numbers of people who are stacking up with a known diagnosis and nobody knows where they are is going to the roof. So we're doing a really valuable amount of digital outreach to drill into people and then peer engagement. And we're very good at finding people. The research agenda keeps us alive and we contribute to an enormous amount of guidance. But fundamentally, this is a conversation about inclusion health and about what we can learn from inclusion health. And I feel this is quite an interesting place to have this conversation because, you know, we've got Bob's Museum just round the corner. Robert Koch, you know, the godfather of medical microbiology, you know, has to be, you know, you have to be in awe of the way he pieced together his postulates. And that lecture was clearly a turning point in human thinking the world over. But I have a favourite anti-contagionist. Everybody likes anti-contagionists, don't they? You know, we're in a post-truth world after the pandemic now. I'm allowed to talk about this. My favourite anti-contagionist is Herman Pidew, who was a French physician, possibly the progenitor of social medicine as we understand it today. And Pidew was on a slightly different path to Koch in terms of, you know, how to remedy TB. And he had made enormous progress through measurement and understanding tuberculosis. And he truly believed that, and was about to get funding for a national association to remedy what he considered to be the cause, which was appalling malnutrition, particularly in young children, appalling living conditions, and very dangerous and unsafe working environments. And he said this was driving TB, and he'd done it through measurement. He understood that, you know, the foul air and the squalor and the hunger was putting you at risk of developing this manifestation. The data were interesting, though. There was quite a few rich people who were also getting TB, and he accounted for that by saying that TB also found its niche in excesses at table and the torment of ambition. So, yeah, I think he's probably right there as well. But nevertheless, along comes Koch, and he annihilates Pidew's argument. And he pretty much opened the door to balicide, as it were. Every effort was then directed toward killing the organism, you know, even at the expense of the patient in many instances. And it took another half a century before we had anything like an effective regimen. But, you know, we've had an effective regimen to kill TB bugs for over half a century. And we have a global pandemic, and TB has regained its gold podium position as the leading killer from any single infectious agent on this planet. So the challenge is, we're not going to win with this biomedical model. TB is a very clear illustration of that. We cannot win with this biomedical model, and we need to look back and forward and open our minds and do what we as human minds are most able to do, what almost sets us apart. We're able to be cognitively dissonant. We're quite good at simultaneously entertaining two competing ideas. Yep. So let's get back into that model. There's room in all our heads for both Koch and Pidew. Let's get Pidew back in our heads and start thinking about a biosocial concept of medicine, of social cure. And if we're ever going to design a service or any intervention whatsoever in terms of healthcare, let's use this concept. Let's think about the last person first. Let's move away from our low fruit model, because the last person isn't at the back of this queue. The last person doesn't know that the queue is there. And we have to start to think more creatively. Thank you very much.
Thank you, Al, for this inspiring talk, and I'm happy to start the conversation. Are there any comments or questions?
Good.
Yeah, thank you very much for this really excellent talk. I like a little bit controversy. And I want to ask you, you mentioned syndemics, and I think it was 2016, 17 that The Lancet published a series on that. What I missed there, and something you advocated yet very much, is cultural change and to look at the cultural dimension. To what extent do you think culture also needs to be taken into consideration for all of these things? And would looking at, you mentioned just now a new epistemological system where you say, okay, we have evidence, we have other evidence, now look at how we get forward on that. To have the concept of societal cognitive dissonance, that we don't like to look at certain things, and that might be also part of the answer to the question, why don't we look at prison systems? Why don't we look at death? Why don't we look at all the things we don't want to look at? So back to the question, do you think we should not have syngenics, but syncogenics and have culture in there?
Culture, I think, is a term that should probably be reserved to trying to grow mycobacteria. I mean, I think the concept is robust enough to not require the idea that it would be necessary to compartmentalize different people within it, as it were. The entire agenda is about trying to move away from the trap of logical reductionism, which has led us down many dark alleys in the past, and move into a more expansive and inclusive way of thinking that tries to look beyond the labeling, the compartmentalizing, and the othering, as was used, to a rights-based approach to care that sees us all as equally deserving, and most importantly understands that we are a chain that is as strong as its weakest link. And if we fail anyone, we fail all. Infection, again, is a good lens to look at that through, for the simple reason that TB anywhere is TB everywhere, for the simple reason that, as a dear colleague of mine said some years ago, we have to get out there, we have to find people with Hep C, and we have to treat them so that when my kids grow up, they can inject safely. So we need a wider way of thinking about it. There is a true enlightened self-interest at the heart of this. And as public health thinkers and public health professionals, we are intrinsically political, but we have a duty to extend the love and knowledge of our discipline into all domains.
No, it's working. Okay. First, Al and also Iman, thank you very much for the talks. Just to let you know, I received messages thanking us for inviting you. So great talks. Thank you very much. My question regards a little bit to the whole Find and Treat program, which was, as far as understood, like an emergency reaction to a specific situation of not reaching the vulnerable ones. And we see that TB, but also the other diseases, is focused more and more to the vulnerable groups. Hard to reach, what we don't, they are, but we don't reach them. So the question for me is, we know that adapting our care systems is pretty hard. So we are kind of skeptical if we can implement such things in our normal care system. So is it maybe more useful to implement this on a much broader, on a general scale, and get rid of the normal system?
I think both, but I think you can do a lot of this under the wire. And the reason why you'll get away with it is because nobody really cares. You can do an enormous amount under the wire. And I think you can start way ahead where we started, because you can start by building a workforce that isn't designed around a chapter in a textbook or someone's clinical expertise or interest. You can start by building a workforce from the affected communities, made up of the affected communities, and you can start giving away that power through training and extending roles and extending responsibilities. And you make yourself useful to the system. One way you will be useful is in improving the air we breathe. We all share the same air. That is a good argument to come in on. One way you will be useful is in improving the life chances of people who come in contact with the service. And again, goes back to what Eamon was talking about in terms of the prison system, this revolving door, etc. We're all about trying to break cycles by building those relationships. And again, if you can evidence the fact that engaging with this community-based service for a journey through TB treatment, onto your HIV therapy, through Hep C treatment, into harm reduction, etc., is massively reducing your use of public services, in inverted commas. From a health economics perspective, we never talk about this, but I could say quite a few people who work for us were formerly net users, quite high-end users of emergency departments. A few of them had quite a high arrest rate. They'd been incarcerated. They were costing the taxpayer a lot of money. They've been paying tax for over 10 years now. That's worth millions. It's worth millions. The amount of economic value in literally that switch, throwing that switch, is incredible. You can make some very strong arguments to actually make the workforce, their job is to use their lived experience for our collective good, and they are worth a fortune. You get one into post, it's worth millions. You can build the service from the roots up under the wire, and no one's going to stop you.
Thank you very much to both of you for these presentations, which were great. So my name is Anna Kühn. I'm from the University of Dresden, but in a role that's partly with the local public health authority in a place that's probably a lot less focused than London. And my question relates to the previous question about scalability in places where this might not have the same attention, might also not be the same scale of, if you want to call it a problem for the people that are affected, really. Which of these parts are absolutely fascinating have you scaled up out of London, and which worked, and which are sort of the things where you feel this is something that you could do? You've elaborated a little bit on start to hire people from the community, which I love as first bit. Do you have a few more ideas on what are the things, what are the pieces of the program that you could scale up in places with maybe less money and maybe an even more marginalized and invisible population that's affected by the program?
Yeah, sure. One thing we do a lot of is health advocacy. So again, we achieve a lot of our work in partnership with third sector organisations. The key is partnerships. We work with Hep C Trust, work with Groundswell, work with lots of other national organisations. And one intervention that we've set up and has scaled nationally, just one example, would be the Health Advocacy Partnership. So this works particularly for people who are, their vulnerability mainly relates to their migration status, their lack of rights, and the sort of animosity in their immediate environment, or people who are on the street, particularly people experiencing homelessness. And that literally is just about explaining how to use a health system and advocating for them and accompanying them. And through the lens of street homelessness, we took a DNA rate for GP appointment, I did not attend, from 60% down to 6%, with an intervention that cost almost nothing and was literally just about going with people and advocating for them. And it was people with lived experience going with other people with lived experience. But we gave them a card. We gave them some power. We gave them something to wave. We gave them a mobile phone. We gave them a badge, a nice lanyard. We dressed them up. We played the power game, and they were able to advocate incredibly effectively, particularly for vulnerable migrants and people experiencing homelessness. That is an intervention that almost cost nothing, but started to make a real difference in terms of getting people access to the services that were entitled to.
Thank you. We take one very small question from the
Yes, I
chat.
take the smallest of the three we have. Do you provide HIV PrEP in the bus?
We do. Yeah, we do a lot of out of hours work, and sex worker is a broad spectrum. We work with street sex workers, and in terms of vulnerability, they're probably some of the most at-risk populations that we serve. We also work with the Johns, as they're called. We've got quite a few guys who are very happy operating in that sort of an environment and get out there and talk to people. That's an area where we could really do a lot more work in terms of not only finding bugs and doing good work there, but in terms of advocacy. A lot of these women are trafficked, and incredible vulnerability. But yeah, PrEP is available. Pretty much if you ask for it, we'll find it from somewhere. Yeah.
Thank you very much.
Thank you. Thank you very much.
Thank you again.